Today, I want to take you inside one of the most fascinating and unsettling cases I've ever come across. A case that began with what seemed like mild, everyday symptoms and ended with a life-or-death race against time. It's the story of a woman whose life was hanging by a thread, a diagnosis that eluded the best doctors in the room, and a twist that nobody, and I mean nobody, saw coming. I want you to join me, not just as a listener, but as a detective. Together, we're going to break this case wide open. My name is Dr. Jennifer Williams. I'm a specialist in internal medicine, and I want you to learn how to think like a doctor. So, settle in. You're about to step into the shoes of a physician in the middle of a mystery. It's a sunny afternoon in a quiet suburban neighborhood. Andrew and Emma, a married couple in their early 40s, are enjoying what should have been a completely ordinary day. Lunch has just ended. They're chatting about weekend plans, maybe taking their dog for a long walk, maybe doing a little gardening. But then, Emma's world shifts. At first, it's subtle. A wave of exhaustion washes over her so suddenly she has to drop into a chair. She thinks, maybe I just ate too fast. Maybe I'm dehydrated. But her smartwatch buzzes on her wrist, delivering a message that makes her frown. Her pulse is slow and irregular. She stares at the screen. Slow? Irregular? She's not an athlete. Her resting heart rate has never been this low before. Still, Emma isn't the type to panic. She tells herself it'll pass. She's busy. She has a job, a home to run, people counting on her. She's not about to waste half the day sitting in a crowded ER waiting room. But her body has other plans. That evening, a gnawing cramp starts twisting her stomach. Then nausea. Then vomiting. She runs through the possibilities in her head. Food poisoning? No. Andrew ate the exact same lunch and he's fine. A stomach virus from the daycare where she works? Maybe. Kids bring home all sorts of bugs. She decides it's probably viral. Nothing to do but rest. But the next morning, she wakes up worse. Her chest feels heavy as if someone's sitting on it. Her heart flutters unpredictably in her chest. Every movement makes her feel drained. And this is where, if you or I were telling her story in hindsight, we'd be screaming, "Go to the hospital. Now." But Emma? She's still hoping it'll pass. She's stubborn that way. It takes 3 full days. 3 days of nausea, vomiting, chest pressure, palpitations, before Andrew finally convinces her. Enough is enough. They get in the car and head to the emergency department. I want you to imagine you're me, a doctor standing in the ER when Emma walks in. The clock starts ticking the second she arrives. Chest pain, nausea, vomiting. These are red flag symptoms. They could mean heart attack, inflammation of the heart, a blood clot in the lungs. Any of these could be fatal if you miss them. You can't afford to be wrong. First stop, vitals. Her blood pressure? Normal, that's a relief. Her heart rate? 53 beats per minute. Now, 53 can be normal in athletes, but Emma isn't one. Given her symptoms, this slow pulse is our first clue. So what's causing it? Could it still be a heart attack? She's young, no smoking history, no early family heart disease. But I've seen heart attacks in people with no risk factors before. We keep it on the list. For a heart attack, we look for 3 things. 1, symptoms. She's got chest pressure and nausea. So check. Second, troponin level. This blood test detects heart muscle stress or damage. Her result? Normal. That's promising. 3, ECG. This is where things get interesting. I pull up her ECG tracing. To most people, it's just a series of squiggles. But when you train your eyes, you start noticing tiny details. And here, between 2 specific peaks, there's extra distance, a delay. The heart's electrical system isn't firing quite the way it should. That's not something we ignore. We move fast, ordering more tests to rule out the other deadly causes. CT scan to check for blood clot in the lungs? Negative. Chest X-ray for pneumonia? Clear. Imaging for aortic dissection? A tear in the body's main artery? No signs. Every result feels like a small victory, but we're still in the dark. Her heart rate is slow. Her ECG is abnormal. She's still symptomatic. The emergency doctor looks at me. We both know we're not sending her home. Not with these findings. We call in cardiology. What happens next sets the stage for one of the strangest and most unexpected turns I've ever witnessed in medicine. When the cardiology team walks into the emergency department, The air in the room changes. These are the specialists you call when something's wrong with the heart, and you're running out of time to figure out what. They're calm, professional, but I can see it in their eyes. They know something about Emma's case isn't adding up. The cardiology fellow greets Emma, takes another quick history, and orders repeat tests. Because in medicine, one normal reading doesn't mean you're safe. They recheck her troponin level, still normal. But when they run another ECG, everything changes. The tracing isn't just a little delayed anymore. It's worse. The heart's electrical signal isn't simply slowed, it's blocked. Completely. The cardiologist pulls up a chair beside Emma's bed. He says quietly, "You have what's called a complete heart block." She freezes. The phrase heart block hits her like a punch. Her mind instantly jumps to, "I'm having a heart attack. I'm dying." But he explains, "This isn't a blocked artery. This is electrical failure. The wiring inside her heart has short-circuited. Your heartbeat isn't random. It's run by a tiny natural pacemaker at the top of the heart, a cluster of specialized cells that send out regular electrical impulses. That signal passes through a narrow checkpoint, the AV node, which times the beat perfectly so the top chambers and bottom chambers pump in perfect sequence. In a complete heart block, that signal never gets past the checkpoint. The lower chambers are left on their own. They can beat thanks to a built-in backup pacemaker, like a generator kicking in during a blackout. But it's slower, weaker, and dangerously unreliable. The only reason Emma isn't collapsing on the spot is because that backup generator has kicked in. But it's a shaky lifeline. And if it stops, her heart could slow to a crawl. Her blood pressure could crash. She could die before we even have a chance to get her into the cath lab. We stick external pacer pads on her chest, large adhesive patches that can deliver life-saving shocks if her heart rate drops too low. She's transferred to the cardiac care unit, where we can watch her heart rhythm beat by beat, 24 hours a day. Now that she's safe, for the moment, the real detective work begins. Complete heart block doesn't just happen for no reason. Something caused this. We start a list. Medications? None. High potassium? Number thyroid problems. Number myocarditis. Inflammation of the heart muscle? Troponin says unlikely. Coronary artery disease? We'll need imaging to be sure. An echocardiogram shows a structurally perfect heart. Normal size, strong squeeze, healthy valves. Then a coronary angiogram, threading a catheter into her heart to look directly at the arteries. Clear as glass. We're running out of options. With every test that comes back normal, my mind drifts toward one rare diagnosis: cardiac sarcoidosis. It's an autoimmune condition where tiny clumps of immune cells form inside the heart, sometimes blocking the electrical signal. But proving it? That requires a cardiac MRI or PET scan, neither of which this hospital has. We'd have to transfer her. We're discussing the transfer when Emma's monitor suddenly erupts with alarms. On the screen, her heartbeat transforms into something terrifying: ventricular tachycardia, a deadly, chaotic rhythm that can send a patient into cardiac arrest in seconds. Nurses sprint into the room. Defibrillator ready, hands hovering over the shock button. Then, as quickly as it started, the rhythm stops. She's back in sinus rhythm, but that scare tells us everything. Her heart isn't just slow, it's unstable. We're running out of safe time. While we stabilize Emma, she asks us to call her husband, Andrew. He's been by her side almost every day. But today, for some reason, he hasn't shown up. We try his phone, straight to voicemail. We try again, still nothing. Emma looks worried, not just for herself now, but for him. She says quietly, "This isn't like him." A few hours later, I'm paged down to the ER again. There's a new patient, male, early 40s, complaining of chest pressure, weakness, and a slow, irregular heart rate. When I walk in, I freeze. It's Andrew, Emma's husband, and his ECG looks disturbingly familiar. This is no coincidence. Two healthy people, married, living in the same house, arriving at the same hospital within days, both with slow, unstable heart rhythms. Something's connecting them. Something in their environment, something that's attacking both of their hearts. We just don't know what yet. Two patients, two hearts misfiring, one marriage, one home, one mystery that could kill them both. I've seen strange coincidences in medicine before, but this is different. This is dangerous. Emma is upstairs in the cardiac care unit. Andrew is downstairs in the emergency department. Both of their heart rates are slow. Both have abnormal ECGs. Both are otherwise young and healthy. This isn't genetics. Heart block doesn't suddenly appear in two people in their 40s at the exact same time, which means one thing. They've both been exposed to something. We start asking Andrew the same questions we asked Emma, but now every detail matters. Had they traveled? Eaten anything unusual? Started any new hobbies? Andrew hesitates, then mentions something small, almost as an afterthought. He recently built a vegetable garden in their backyard. Their neighbor even gave them some plants and herbs to get started. And on the day Emma first got sick, he'd surprised her with lunch. Fresh salad, straight from their own garden. He says it proudly at first. I picked some kale from the garden and mixed it into the salad. Emma, hearing this from upstairs when we connect them on a call, remembers it too. The kale tasted unusually bitter. They'd been so excited. Homegrown vegetables straight to the table. No pesticides. No supermarket middleman. Just pure, green, healthy food. Or so they thought. Hours after eating the salad, Emma started feeling sick. Days later, Andrew followed. If this was food poisoning, it should have hit them both at the same time. But toxins can work differently. Some people get sick faster depending on how much they ate, their metabolism, or even the way their body processes certain chemicals. This isn't bacteria. This isn't a virus. This feels like a poison. We send a family member to their house with instructions. Go to the garden. Collect samples of every single plant. Bring them to the hospital immediately. In the meantime, we order toxicology screens on both Emma and Andrew. When the lab calls with the results, my jaw tightens. Both of them have high levels of digoxin in their blood. Digoxin is a powerful medication made from a plant called foxglove. In small, carefully measured doses, it can be life-saving, helping certain heart conditions by slowing and strengthening the heartbeat. But in high doses, it's deadly. It causes nausea, vomiting, weakness, vision changes, dangerous heart rhythms, and yes, complete heart block. They're not taking any medications. So how did digoxin get into their system? Then it hits me. Foxglove, the plant. That so-called kale Andrew picked from the garden wasn't kale at all. It was foxglove. Now, you might be thinking, how could anyone confuse foxglove with kale? Foxglove in bloom has beautiful trumpet-shaped purple flowers, nothing like kale. But here's the twist. Foxglove doesn't flower in its first year, and some kale varieties have leaves that look eerily similar to first-year foxglove leaves. If you don't know what you're looking at, you'd never know the difference. Both Emma and Andrew mentioned something strange we hadn't asked about before. Their vision has been off. They're seeing halos around lights, yellowish rings. This isn't random. Digoxin toxicity can cause this exact visual distortion. In fact, it's believed the famous painter Vincent van Gogh experienced this after being treated with foxglove, and that it may be why he became obsessed with the color yellow in his paintings. Now that we have a diagnosis, there's no time to waste. We prepare the antidote, digoxin-specific antibody fragments, also called Digibind. When injected, these antibodies latch onto digoxin molecules, neutralizing them so the body can safely eliminate them. The first dose goes in. We watch their monitors. Within an hour, Emma's nausea begins to ease. Andrew's color returns, but their digoxin levels are dangerously high. It takes 12 vials in total, spread over several days before their heart rhythms normalize completely. Their vision clears, the nausea disappears, the weakness fades. When they're finally discharged, Emma and Andrew return home and take a long, hard look at the garden that almost killed them. The foxglove plants are removed immediately. They have a conversation with their neighbor about plant safety, and they promise themselves, and each other, to never eat anything from the garden unless they're absolutely sure of what it is. Here's the thing. Emma was lucky. Andrew was lucky. Had she waited any longer to come in, had we not made the connection between their cases, we might have been telling a very different story. And there's another lesson here, one I tell every patient, especially women. Never ignore chest pain, palpitations, or sudden weakness, even if you think you're too young for heart problems, even if you think it's nothing. In medicine, timing is everything. And sometimes, The difference between life and death is just one question you remember to ask.